So I want to welcome onto our panel. This is about improving access to innovative medicines. I'll leave this space free for Anya. Hello. Right, come and join us. That's right, don't run. It's okay. Oh, yeah, good.
The microphone.
That's brilliant. I know these chairs are a bit tricky. I know.
They're just going to need to be wired up.
Yep.
Oh, or we can use a handheld.
It's quick. Come
Yeah,
here.
okay.
I know how this works.
Okay, I'll get started in the meantime and introduce everyone. So we're really talking about overcoming barriers to provide timely access, and we want to talk about, there's this new recommendations about EU health technology assessment. We can ask about that, and we really want to look at sort of concrete suggestions for how we can improve access, but in favor of outcomes. That's what's important. Accelerated access in favor of outcomes and patient quality of experience as well. So joining us on this panel, Adrian Griffin, Vice President, HTA and Access Policy, Johnson & Johnson, MEP Tomislav Sokol, Member of the European Parliament, as I said, Karis Givalaki, have I pronounced that correct?
Yes.
Thank you. Karis Givalaki, Director of the European Cancer Patient Coalition, Mark Lawler, Associate Pro-Vice Chancellor, Professor of Digital Health and Chair in Translational Cancer Genomics at Queen's University Belfast, Anya Schiel, Lead Methodologist in Regulatory and Pharmacoeconomic Statistics at the Norwegian Medicines Agency. So again, as many of our sessions, it's great to have these different perspectives, and that's what we're here for. It's very important that we do get them. I'm going to start with Tomislav, if I may, just talking about what's in the European Beating Cancer Plan in terms of improving access to innovative medicines and what can be built upon there, and what's your vision?
Yes, thank you very much. So the Europe's Beating Cancer Plan is the first, let's say, systematic plan on beating cancer, but including all the stages, from research to prevention, early detection, treatment, and aftercare and afterlife for cancer survivors. So in that sense, it's very important. But I have to say the part on treatment, actually, is the least the concrete part of them all. The biggest focus is on prevention and early detection, but also on research. So when we speak about access to innovative medicines, I think the research part is essential. So the fact that beating cancer is one of the priority missions of the New Horizon program, but which was already before the Beating Cancer Plan, but this is something which is strongly referenced in the plan, and also a very high focus on research in general within the Europe's Beating Cancer Plan. So I think that is important. And second part, so in that area relating to access and treatment, one of the things which are really emphasized in the plan is the problem of inequalities. So the fact that access to cancer treatment and innovative medicines in general in Europe is very different. And I have to say that since I come from an eastern and smaller member state, Croatia, I can say that this is definitely a fact. But unfortunately, I think the plan does not go very far in terms of providing concrete measures on how to address it. So in terms of concrete legislation and concrete financing, so I think the plan could have gone much farther in that respect. It does provide for establishment of European Cancer Inequalities Registry, which is a very important thing in terms of data collection. But I think there are some other things that we have to address. But what I would like to emphasize is that the European Parliament Special Committee on Beating Cancer, in its report, emphasized the necessity to facilitate equal access to innovative cancer care and cancer treatment in all member states. And it mentioned some of the measures which were, and proposed some concrete measures, like, for instance, joint procurement of innovative medicines. And I think this, I think this is an idea which has become one of the focal points of the European Parliament's work in the area of cancer and healthcare in general. So the idea is to use the experience that we had from the pandemic, when we had joint procurement of vaccines, to also do this for expensive medicines, especially for rare diseases, rare types of cancer, etc. Of course, this is only one possibility. I think this idea, this proposal from the Parliament has also put a pressure on the industry to actually think about alternative ways. So now they are trying to think of alternative ways how to facilitate access in those member states where that is a problem, which have less financial capability to pay for expensive drugs. So I think that, so I believe that in the end, something good will come out of it. Maybe not joint procurement in a sense as we had with vaccines, but some other alternative possibilities, like for instance, adapting the prices to the financial capabilities of individual member states. So some kind of a solution which will facilitate access to medicines definitely will come out of it. Of course, we are now waiting for the pharmaceutical legislation revision. This is very important. Also, this is also something which is mentioned in the Europe's Beating Cancer Plan. Of course, we have to see what will be the result of it, but I would just like to emphasize that in the Parliament there are different visions and competing visions on how this should be organized. But in principle, what I would like to say, it is important that we maintain the incentives for development of new and innovative medicines. I think that's crucial, because if we do not maintain the incentives for some populist reason, because there are some populists in the European Parliament who just want to attack industry, but they don't care about the consequences. And the consequences are that we are in the global market, that we compete with the US and China. And if we don't provide the right incentives for the industry to remain in Europe, then they will just move to other parts of the world, and then we will even more lag behind than we are lagging behind now.
So interestingly, the key points I take away from that anyway was one about how access starts at development and R&D, and so incentivizing that's going to be critical. Also that inequality doesn't only exist geographically, but temporally, that some places get access before others. Also, there's different abilities, that the financing is different in member states, and also there's the healthcare infrastructure to deliver some of these complex and innovative treatments might also be different.
Yeah. If I may just refer to that, so one of the big problems is pricing and reimbursement. And here we have the problem of competences. So that is a competence of the member states. Right. So member states decide which medicines will be paid and at what price. So social security, healthcare, health insurance funds. The only directive which regulates this, which sets some parameters and set some limitations on how member states should do this, is Transparency Directive, which is 33 years old, which just says that you cannot discriminate. So you cannot charge higher price for foreign produced medicines when compared to domestically produced medicines, but that's it. But so I think this is a problem. This directive should be amended. We should make a new directive which will set some principles, for instance, of cost effectiveness, which should be taken into account by the member states when they make these reimbursement decisions, and also which will make the national systems much more transparent than they are now, because there are vast differences. Some member states really have a clear-cut, transparent system with clear criteria on what will be funded and what not, but in some other member states, like in my member state, for instance, this system is very opaque, very non-transparent, and you really don't know how these decisions are made in the end. So I think that it is legally possible that we adopt at least some overarching principles which member states would have to respect, but of course the final decision is up to them.
Hence the HTA recommender. Adrian, Tomislav alluded to some of the responsibilities that industry has in terms of responding to that. So, would you want to address that question?
There's a lot of issues on the table there, isn't there? I think one of the challenges that we have when we're bringing new innovative technologies to market is, as you rightly said, we are working in a global environment. With each technology, we're working with a single development plan, which has a body of evidence, which we are then, we have a large regulator in the US, we have a large regulator in the EU. But then when it comes to market access, we're working with a very diverse set of customers, all who have very different value structures. And so trying to put a single value assessment, a value framework, is very challenging. We're also then dealing with different degrees of infrastructure and funding in the system. And so whilst access and pricing of pharmaceuticals tends to be the issue that gets the newspaper headlines, actually behind that are a lot of other issues around the degree of screening, the degree of resource within those diseases, the ability for patients to be diagnosed and access. And so yes, access to medicines is one of the restrictions, but from a company perspective, we're looking to balance off all of those issues across a couple of hundred markets, in a timely fashion that will get access for patients who have the ability to receive them locally. And what we find that works best when we're bringing our innovations to market is the ability to be flexible and work locally with decision makers. So, for example, using the European sort of microcosm, because that's where we are today, although there's a global environment beyond that. Although we go through the EMA to get our regulatory approval, when we're then talking about pricing and reimbursement, it's in our interest to get that technology to as many patients who need it. It's the reason we are here as a company, and we've been here for over 130 years now, is because we can deliver innovation. And people are valuing that innovation, and that allows us to keep that model going. What we find works is if we can help define what that value looks like in that local environment, we can come to local agreements around pricing and access. And the way that works is by being flexible and being able to come to local pricing and access agreements that work within that local environment without the unintended consequences of issues like pooled procurement, parallel trade, for example, that then undermine our ability to keep that sustainable model moving forwards. I think there are opportunities to collaborate more. It's worked on the regulatory side. There are attempts at the moment on the HTA side. It's challenging at the moment to see how that's moving forwards, and perhaps a bit of a discussion on that later would be interesting. But I'll stop there in the interest of time.
Great.
Yeah.
Okay. Karis, European Cancer Patient Coalition you're representing. I mean, I'm assuming that you're quite engaged in the discussions in a European level. So what's the position that ECPC take? I mean, please build in your personal views as well in terms of access to innovative medicines and what we need to do.
Well, what we are tackling here today is actually one of the most important issues for patients and their access to innovative medicine. And I would like to start by highlighting, let's say, the age factor, in my opinion, which I don't mean the age index factor of, scientific merit or something like that, but the human factor and the importance that innovative medicines and developments have in the life of cancer patients. Because apart from, a new medicine or a device or profit for companies and development in national level for the healthcare systems, for the cancer patients, it's actually new hope for them and their families. It means that they can have better treatment options, or they can have also better quality of life. So this is a very important chapter where our solid positions for many years at ECPC is that patients have an important role to play because they are the ones who can identify the needs and have the knowledge to support the development of innovation and provide solutions that actually fits what they need in order to have better treatment and improve their life, but also their families. So in this direction, through ECPC, we try to participate as much as possible in the public dialogue and try to form, together with the other stakeholders, the legislation that applies upon innovative medicine. And I believe that in the next steps of the discussion, we can elaborate a bit more on that. And it's actually a responsibility of all of us to find ways to incorporate the patient's also position into this process, every step of the way.
Okay, well, that's something we could definitely explore as well, is that getting the patient involvement in access processes. Anya, I'm going to come to you now. There's the age-old question of we want innovation, but we also we have limited resources, and the whole point of these access mechanisms is to help us allocate limited resources. And the innovations are coming thick and fast. They're ever more complex. We have methods that are methods, but they may not. So and I noticed yesterday when we had the session, you put your hand up to say the HTA process or the access mechanisms do need improvement. Isn't that right? That you were one of the, yeah. So what do you think about this as someone who's sitting on the access side, on the access regulation side, as it were?
Yeah, well, you know, there's so many things that have come up over the last 2 days, and I'm really trying to put them all together. And I think one of the things that we jumped constantly from the individual perspective to the societal perspective to the commercial perspective. And those three are all very legitimate positions to have. And all of them have their own interests, and we have to respect them. That is one of the core elements that we really have to change. If we want to change the system, then we have to start by respecting each other. Yeah. But we also need to understand that there's something that's in my world called the death by pilot. Mm-hmm. We have good intentions. We start all kind of programs, but we are not really, you know, make conclusions out of them. And we had that also yesterday. So you need a strategy. And as a matter of fact, just saying, well, it's so difficult to measure whether the things we implemented have an impact, that's not a good enough argument for me. You have to come up with some metric that actually measures success. And you have to define it. And you also have to define your goals. Where do we want to be in 5 years? And what is the driving force behind it? Do we want, you know, drive innovation just for innovation? Or are we accepting that innovation is only as good as our systems to actually use that innovation? And there is this part of, yes, we have limited resources. Everybody is aware of the simple fact that you have to make everyday choices on your budget. Yesterday you said something, and it was very casual that you said, well, a euro spent here is a euro not spent there. It's worse. As an HTA, I know a euro spent here means taking away a euro from someone else. That is a far more serious consequence of my decision makers, and I have to tell them, you know, how certain I am. And the only way forward is to really, you have to accept the other perspective. We are criticizing, you know, the industry is criticizing the HTAs for being, you know, a blocker. That's not true. My mandate really is, I am supposed to bring the best, but also the most cost-effective drugs to the patient. And that means, you know, let's face it, if you want a premium price, you need premium evidence, because otherwise we have to balance something else with maybe previous premium evidence, or a long history of how it works. And we know exactly how it works, and we know how toxic a chemotherapy is, and we can tell the patient exactly what they can expect, and we can't do that for a new drug. These are the balances that are constantly trying to juggle the different perspectives. And we do take the patient perspective on board, obviously. You know, we work with the most objective way of assessing health technology. That's the cost-utility analysis. It includes the quality of life of patients. It includes that every company that comes has to bring their health economic module to us. They know exactly which assumptions they're making and which options we have to disagree on assumptions. It's an extremely transparent system. But I totally agree. I know a couple of my other European colleagues. Opaque was the word you used. That's an understatement of the day, calling it opaque. It's sometimes not comprehensible how they come up with their conclusions. I agree on that. Are we working on that? Yes. Is the HTA going to solve all the problems? No. That's the unfortunate reality, because this small step to it remains a national decision, which is not unlogical, because, you know, every country is different. We have to accept that. Mm-hmm. That little transition is what makes the whole thing either meaningless or useful. Mm-hmm. And there is a very, very thin line in this HDAR, where, you know, we probably don't all agree on how far we can go and what we can achieve with it. But it all starts with, you know, accept that the other ones have a legal mandate to have their perspective.
Yeah. Okay. So, I mean, I'm already, you know, as expected, there is, I like the way you're putting it. I mean, I think there need to be constructive solutions, but there is necessarily, and I'm sensing it here, there's a slight adversarial perspective to this, perhaps. But I would like to, the whole point of this is to find constructive way forward. And I think we all appreciate, I hope, the different perspectives that are being brought here. And maybe that's something we could explore with your help as well. But Mark, what do you think about, how do you see this? Is there a middle way or a way of finding compromise between these two different...
I think there's a couple of things to think about. I think the first thing is that COVID and the pandemic has changed everything. So we're in a totally different environment from where we were before. We realize that some of the systems we thought were resilient, although some of us were saying they weren't resilient, aren't as resilient as we thought. So I think we have to recognize that everything is on the table in terms of, not necessarily just doing the same old again in a new setting. I think the other really important thing is we need to look at ways in which we can take it as part of a whole innovation life cycle and innovation. So medicines are one part of that. I think the danger is if we just focus on the medicines, we're going to actually lose out in terms of what's the real way in which you can bring in innovation. I was in one of the sessions there at the coffee break, and one of the things we were saying was, innovation doesn't necessarily have to be expensive. Everybody talks about innovation and then the same word, euros, dollars, things. And I think that's not a good way of actually dealing with it, because we actually have to see, well, what's the best way that we're actually going to introduce something new that's actually relevant to the patient? So if we look at it in the context of medicines, we also need to have diagnostics in place. If we don't have diagnostics in place, so if we don't have pathology, for example, we can't have precision medicine. So that means that we have to think about a whole system approach rather than just saying, I just want to get my medicine in here, approved and sold. That's the sort of revisionary view of it. It needs to be, how am I going to use it in the system? How does the system approve? How does the system evolve to let me actually deliver this for the best value for patients?
Please put your hand up if you have questions.
The other is implementation.
Right.
Because I think that's the other thing we're not good at the moment, and we really need to think about it, and we need to invest in how do we actually implement change.
Right.
Because change management in general we're not very good at, in medicine in general, but particularly in this space.
Sure. Benedict? We just need the mic. Yeah. We've got a dead mic. Yeah, speak up. Yeah.
Here it comes. Here it comes out.
I like the idea of high-quality evidence drives high-quality prices. The question that we've been discussing is, the system has changed. The way we look at patient populations has changed. But we look, by defining evidence, we still look the way we've run clinical trials in the past. This morning, data came out in pancreatic cancer, 770 patients randomized. We don't know what to do with this data. So with these ever smaller subgroups, how are our methods evolving in the future to define what is real high-class evidence?
I think it's not straightforward to define high-quality evidence because, as said, if a very rare cancer is coming or an orphan disease, then no one has skyrocket high expectations on what kind of evidence you are going to deliver. In the contrast to EMA and the regulatory approval, there's a miracle, there's a p-value, the primary endpoint, the statistical robustness, and the inferential framework causality. That's all that counts. When you come to the HTAs, and I work as a statistician, the rules are off. We treat the endpoints differently. We see the whole package. We take the endpoints that are relevant and might ignore other endpoints. And that seems to be very confusing for the industry. But this is something you just have to talk to us and you learn how we think. We think much broader. We think context. That means that, sometimes it's your secondary endpoint that's the most relevant. That one has to be robust for the HTAs. Or, and I recalled it a couple of years ago, I told a company in a meeting, if your claim is that the quality of life is improved by your drug, why wasn't that your primary endpoint? And they look at you as if you're from the moon, And they say, nobody in the regulatory world would ever approve that. And then I say, yeah, but who's the bottleneck here? Is it the regulatory approval, which you probably get with very little, or is it the HTAs? And if that is your claim, that's the one you have to bring evidence for, nothing else. So robust, or good enough, or high quality, or fit for purpose, all terms that have no definition. And I agree, it's difficult to deal with that, but it's not difficult if you make these agreements in the beginning of a development program, and you have in between discussions on, are we on the right track? Do we need more patients? Could we do with less patients? Do we need other outcomes that you have to measure? Or do you need to go to the real world and find additional evidence so that in the end I can accept your limited data?
Okay. So we have 3 people, so Adrian, Mark, and then Tomislav. I know you all want to come in this, and maybe Karis wants to as well. So let's go to you, Adrian, first. I think I saw you first.
Thank you. Yeah, I mean, I think we are in a very different time now than we were a decade or two ago with just our understanding of the science, which is driving the type of evidence generation that is now available. Back in the 50s and 60s, we had blood cancer or leukemia and lymphoma, but now we've managed to understand the biologics of that, and we've now got 40 to 50 types of leukemia and lymphoma. We're on the cusp of taking a disease like CLL from an orphan disease 10 years ago to no longer being orphan because of the advances that have been made. But along with that greater understanding of the disease and the medicines that are available, we are getting smaller patient populations because they're more targeted. The outcomes hopefully are improved, and the fact that patients are living longer, which is turning it from an orphan disease to a non-orphan disease, is tantamount to that. But when it comes to the HTA piece, I think we need to also look to evolve that moving forwards. The regulatory system has evolved from one point in time to a more longitudinal reassessment and reevaluating the data. But from an HTA perspective and from a payment perspective, we're still predominantly in that environment where you get assessed at the time of launch, and that's your price. And then there's no real reevaluation as you go on. And actually, what we need to be evolving to is a more interactive approach where you can get a launch, you can get a price. The reason prices tend to start high is because in every European market, whatever your price is at launch, it only goes one way. As you bring more evidence, you bring more indications, your price goes lower. It's kind of a bizarre trade-off that the more evidence you bring, the price is going south. So I think we need to look at reevaluating that at those opportunities. And then within the HTA system, in Europe, we've got 2 key models of HTA. We've got those which focus on on clinical effectiveness, like Germany, France predominantly, and then we've got those that focus on cost effectiveness. Yeah. And there's a key fundamental difference between those 2. The clinical effectiveness agencies say, tell us what you've got and what we know about your product, and we will make a determination on who gets it and at what price. Mm-hmm. The cost effectiveness model is very different. It says, let's start with what you've got, and then we not need to model it out to overall survival and the whole of life, when actually we're getting earlier and earlier in that disease course. So the more effective your treatment and the earlier you become, the greater the uncertainty in the cost effectiveness, which just seems a questionable dynamic in that approach. But we're dealing with those within the same European environment where we have the same European legislators putting models around access and pharmaceutical legislation in place.
Okay. Right. I'm going to go, Mark, I saw your hand next, and then Tomislav, and then did you want to come back as well first?
Just a small comment.
Okay, yeah, so Mark and then Tomislav.
Just to address your question in relation to pancreatic cancer, so there about 3 weeks ago, I was with Eileen O'Reilly from Sloan Kettering, probably one of the best pancreatic researchers in the world, maybe have even written that paper. And we talked about this exact issue, and one of the challenges is the clinical trials framework that we use is not suitable for personalized medicine. So we need to change it. If you look at things like, for example, Focus 4 that Tim Maughan led in colorectal cancer in the UK and in Europe, they're the type of approaches. It was probably before its time in terms of, because there was a lot of challenges in terms of getting different drugs from different companies to actually work together to look at different, parsed out types of colorectal cancer. So we need to look at ways in which we can do it differently now. And Eileen said exactly the same thing, that what we're doing is not the way we should be doing it going forward. And we need to accept that and do it, and not say, because I've probably said that a year ago and it still hasn't changed. And,
Right.
and other people have probably said it 5 years ago and it hasn't changed.
Tomislav, yeah.
Yes, I would just like to maybe explain a bit the framework, who does what, because we often mix what is done on the national level and what is done on the European level.
Yeah.
So first, on European level, we have EMA, which makes the decisions. Actually, the final decision formally by the Commission, but essentially it's EMA about whether a certain medicine should be put on the market. So that's the first thing. And there we have the whole system of incentives, especially for orphan drugs, which has been put in place for the last 20 years. Now we are amending it, which is very important. I think the system of incentives there is one thing that should be definitely strengthened and improved, especially for really, really innovative medicines. So to maybe additional years for market exclusivity. There are a lot of discussions on that, but I think that this system of incentives should definitely be strengthened. But that's the European level. Then we have the pricing and reimbursement decisions, which are done on national level, which also include, among other things, cost effectiveness decisions. But this is based on national criteria, where Europe only says that you cannot discriminate between products from different member states. And then in between, we have the HTA regulation, which was adopted, which I personally don't know where it is, because it's neither the EMA decision nor it is the pricing and reimbursement decision, because that's done on national level. The whole idea of the HTA regulation that it was proposed was actually to substitute 27 national systems and national decisions for one common European system, and if that succeeded, that would have been fine. But unfortunately, member states in the Council, especially some big member states in the Council, blocked that. Parliament wanted this, Commission wanted this, but the member states didn't want that. Some member states, and because of this, the whole system was diluted. And now we have the situation that instead of having one system substituting 27 national systems, now we got the 28th system, which member states should take into account, but they're not under a legal obligation to do so.
Right.
So this HTA is a big missed opportunity, and it shows us how not to do things on European level. And just one thing that I wanted to add about, one important topic are rare diseases. And obviously, rare diseases are also not fit for purpose for having, especially phase 3 clinical trials, because you just don't have enough patients. So this is one area where we have to think about real-world evidence, etc. And I'm glad that EU has actually come up with the proposal on the regulation on European health data space, which should really, if it is adopted, should make a turning point at that, because it should create one common European space where health data from different member states could be exchanged.
Right.
So to create interoperable, so the data is interoperable, that it can be exchanged both for primary use by health professionals, but also for secondary use for research and innovation, etc. Right. And I was appointed the rapporteur on this file, and I think that is very important, because without the data, without having this common European space and possibilities to use data from entire European Union, we will not be able to gather data which is necessary, especially if we speak about real-world evidence.
Sure. Karis.
If I may, a very short comment, taking the opportunity from what Mark mentioned for the clinical trials. And again, we put the question how the research questions that we set when we design clinical trials meet the real needs, so that the results produced from there can actually drive the innovation of producing new medication or other innovative solutions. And I will give you the example of, we all know, of course, that the majority of cancer patients are from 65 and above. And then we go to the fact that most of the clinical trials are not designed to include older cancer patients into the framework. So the results produced from these clinical trials may be, I don't know, very, very important and scientifically valid, but then how they actually, when they are translated into a medication, this medication does not necessarily fit the needs of those that will eventually use them. So this is something that we also need to consider now with the revision of the legislation and the overall European framework.
Okay, Thank you. We've got 7 minutes left, and I know, Francesco, you have a question, but I think Mark wants to go very briefly.
Just very quickly, just in terms of what you said in relation to ageism and cancer care. Unfortunately, it's still there. 2013, we published a paper in the British Medical Journal saying ageism and cancer care. It's now nearly 2023, and we really haven't done that very much about it. So we need to change that.
Okay. So a brief question, please, and brief answers. Yeah.
But I think it's important.
Yeah,
That's
of course,
why
yes,
I'm
yes,
talking.
yeah, sure.
So I think that we are talking about innovation, access, and excellence, and we cannot forget about rare cancer people. Patients that have rare cancer has now the opportunity to go to the ERNS. The ERNS are European network. So the problem is that patients with rare, ultra-rare cancer are mainly cured in the same country where they are. Because if they go in the other country where there are highly specialized things like chordoma or so on, they have no way then to get the pharma because this pharma is not available in all countries. So what I really think that Europe should do is try to work out, since they are spending a lot of money for Eurocan, all the network, but this is implementing the rare cancer in their own country, but it's not implementing cancer from Slovenia or all other countries, because you have, as a parliament, tried to work out a kind of dedicated fund for ultra care cancer to allow patients going from one side to another side, having also the prescription. If you don't make this change, the directive, the cross-border directive doesn't work, and the network, European work, is no patient going there. So why to give so much money for the ERNS if they are not working for other countries where they have not this kind of hospitals?
If I may just respond to that,
yeah. I'm not quite. My ignorance, perhaps, but just could you? What's the issue here?
So we have the EU rules on cross-border healthcare. We have two sets of rules. We have the directive and Social Security Coordination Regulation, which gives patient possibilities to go to other member states in which they are not don't have health insurance if they cannot get adequate care in their own home state.
Right. Okay. Yeah.
So this is the idea, and we have European reference networks, which is the network to exchange best practices, so that sometimes they get diagnostics even without having to travel abroad.
Okay.
But of course, the problem with this legal framework is first, patients don't know about it. It's not well known, unfortunately. It's very complicated, so you need to be really a specialized health lawyer to know what your rights are. And if you go, because you have two sets of rules on price on the reimbursement of this, which are similar but different. So under the directive, you have to go abroad, pay up front, ask for reimbursement from your own health insurance, and then you get reimbursement on basis of the tariffs in your own home state.
Okay.
While under the other rules, Social Security Coordination, there you are sent by your health insurance if they give you prior authorization, and then you don't have to pay up front, or you just have to pay off. So then you have to pay the same amount which are paid by the people in the state of treatment. So if co-payment in the state of treatment is required, then you just have to pay that amount.
Right.
So it's very complicated. It's something that you really have to be an expert on this. This is why we proposed in the Becker report, Committee on Special Committee on Beating Cancer, to merge these two sets of rules on reimbursement and prior authorization to make it much simpler and to give patients the better, so that the patients do not have to go and research by themselves and ask for reimbursement. That this is all settled between health insurance funds. And one last point that we also proposed is that patients, in cases where their own health insurance says, because that happens often, that their own health insurance says, yeah, but you have adequate treatment in your own home state. Why? Because the health insurance fund will ask domestic experts whether the best possible treatment can be provided domestically, and these experts will say, yeah, but we are providing this treatment, right? So they're not really objective on that. So the idea is that we use European reference networks to give people the right to second opinion, so that experts from other member states can say which is the best possible treatment, and whether the best treatment is in their own home state, or they should go abroad. So this is something that was proposed by the Parliament. Now the Commission made an assessment of the implementation of the directive, but of course the problem is that we in the Parliament, we cannot propose new legislation. The Commission is only entitled to propose new legislation, so we are putting pressure on the Commission to revise this legal framework, but we cannot decide this on our own.
Anja, did you want a brief comment, please?
Very brief. A simple solution to this problem would be that all member states need to get access at the same time to every drug. If it's approved, then you have to bring it to the patient, not market it, because that's often just an illusion. Theoretically, you could have it. You need to have access, real access. And that is one of our problems. I mean, we cannot force the industry to sell a product in a specific country if they don't like the conditions, or if they say, well, your reimbursement proposal is not a business model for us. And that's where, there wouldn't be a need for this if all drugs were available in all countries at the same time, but they are not. And not only are they not available at start, they also are not available because we have supply problems. And the amount of products that are not available in some countries is in the 3 digits. Yeah. They are simply not produced enough. But yes, please, let us have even more new drugs when apparently we can't even produce the ones that we really need. That is a kind of a conundrum. And there is, again, competition between the European member states. We are played against each other. 80 million Germans get more access to scarce drugs than the 5.5 million Norwegians, for example. And we, this is a business circle. And sometimes the business rules are applied, and sometimes everybody says, well, healthcare is something different, and we shouldn't behave in the normal business rule set. But it's a bit pick and choose, and we need a better system, and having access really means that at least the company has the intention to give it to you.
Yeah, but also one thing, financial capabilities of different member states are also not the same.
Yeah.
Okay. So in some cases, especially if it is for a rare disease, if you are buying it only by yourself, if there is no common European system or common European fund, then it's just not. Then paying enormous amounts of money for medicine for just 1 or 2 patients is just not, in many cases, cost effective, and then they make different priority decisions. So that's also one of the problems.
I'm sorry. I'm sorry. We will have to, because we're out of time. I'm so sorry.
It's the question, why not make health European?
Yeah. Okay. Well, we can end on that statement.
It's about different countries. It's about patients everywhere.
Yeah.
Okay. It's about a European health union, and
Yeah, I mean,
the whole principle of subsidiarity
Well, we're
is
actually
what we
getting closer to that.
Okay, we're out of time, but be really quick. Okay.
This is defined in the treaties, and some member states don't want to change this because that would mean that they will have to redistribute part of their funding to other member states, and they don't want that.
All right, a wicked problem for which we need more sessions, I think. But we've identified a hell of a lot of problems there. So anyway, thank you very much. We're out of time, and a really good panel. It's got us all fired up. It's fantastic. Thank you.